Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today, we welcome back on the show Natasha Khalid. She's a geriatrics fellow. Her Kevin MD article is titled Remembering My Grandmother in the ICU. Natasha, welcome back to the show.
Thank you for having me always.
So we'll get into the article in a little bit, but for those who didn't listen to our previous episodes together, just briefly share your story and journey to where you are today.
So I am from Pakistan. I did my med school there. I did my training there in internal medicine. And during that, I've been writing as one of my ways of keeping sane and for my love for narrative medicine in all these 6-7 years and for a very long time. And then I came to the States last year to pursue geriatrics as a fellow. So I'm training in geriatrics for now.
All right. So what is it about geriatrics that led you to that field?
When I was doing my internal medicine, we would see a lot of patients that were above 65. And I had a lot of people in my family as well above that age. And I always thought that we needed to go to a lot of doctors for them, to one person would look into the patient as a whole. That was usually an internal medicine person. One person to address a certain issue of neurology, one person to address another things, and nobody was looking into the whole picture, and nobody looked beyond the disease. Geriatrics is also a very developing field, and we didn't have many. I think we just had one in Pakistan who newly came up and was really busy. So it's also something not a lot of people pursue. It's not a saturated field yet. Not a lot of people are aware of it. So geriatrics did, get my interest that way, and I wanted to learn more about this. And in general, I also felt like as an internal medicine person, I was seeing patients more who were in the geriatric population. So I wanted to excel in that as well and be trained particularly for it. So I think that really got my interest to it.
Like you said, there aren't a lot of geriatricians out there. We need more people to go into geriatrics. Now, for those medical students and residents who may be listening to you now, give some reasons why they should consider geriatrics as a specialty.
So, because it's a very interesting field, and everybody who's becoming a doctor or a resident has people in their own family who are in that age group, and they don't know how to manage them, right? And a lot of people from other specialities also don't have the expertise in taking care of it. It's just not the disease, it's more than that. They're looking into the surroundings, they're looking into other things like, is the person elderly being abused or not? Is the other person elderly getting his medications? Is he the one taking them? Is he the one driving? A lot of people are living alone. Do they have all the facilities, or do they need to be put into a nursing home? Then what are the measures that we can take to prevent that dementia from developing? And if somebody has dementia, what are the ways, that could be prevented from further deteriorating? Some health assessments meant, yearly follow-ups with their mini mental skills and stuff, to just see how the mental health is going. How are they able to do their daily activities at home? Do they need help? If they need help, then maybe, you could get the doctor to help you in a lot of areas where people are unaware of. And then, how we have advanced life systems these days. Preventive medicine is on a rise. So that eventually means you'll have a greater population above 65 in the next couple of years. So you don't have many specialized people dealing with 80-year-olds, 90-year-olds, more than that, and you do expect the population to rise in that. So I feel like that way it's pretty interesting. These patients are actually very difficult to deal with as well because, most of them have Alzheimer's or Parkinson's. So they're not like your regular patients that come and, usually have basic diseases and you deal with them. This is also a very complex case. Every patient is complex.
All right. So let's talk about your Kevin MD article. It's a story that you told last year. It's titled Remembering My Grandmother in the ICU. Now, tell us, how did this article come together?
This article came together because I was working and it was a very busy rotation for me. I was in the ER, I remember. And during that time, she had 3 admissions. And these were like weekly. And we couldn't get what was happening exactly. But I remember in one particular admission when I would go, I would see her and I would sit next to her and I knew this is not her being her usual self. I would enjoy listening to things, but then it was also very sad because I was somebody who would see people going under psychosis on a very regular basis ever since I've been an intern, and I was always very confident how this would get better, this would get better. It is ICU psychosis. You come out, you make sure the lights are right, the environment is right, this would get better. When it's your own first one, it's difficult. And, this is the first time I think I was in the shoes of somebody who's an attendant of someone going through this. So I felt like this article that, there was a lot of things attached to it. And this is how it came into writing.
So you mentioned your grandmother and ICU psychosis. So what exactly happened? What happened in the hospital? And what was she like at the hospital that made the team think that?
She presented with, suddenly she had a sudden deterioration, and everybody thought it was a stroke, it was something in the brain. And she was admitted, and they were going through all these tests, but then it just turned out to be it was something else. I don't want to mention it. And that diagnosis itself was surprising. And during, like, when I knew this is, because of a certain thing that all of this is happening, she wasn't being her normal self. Like, she was talking about people who were not there. She was talking about me. She's probably in her subconscious a lot. And then, I've always been somebody, one of the favorites. And that is when I was, actually going through this. And I hadn't been visiting because, like I said, I had a busy rotation. So she also remembered that I don't come. And what was also surprising is once everything was over and I came to visit her at her place, she was like, "You haven't been coming to see me." So she also didn't have a lot of remembrance of the fact that I was around. And I have been very close to her ever since a child amongst all my grandparents. So I think this is also one of the reasons I wrote this, and not for anybody else, but yeah, this is how this article came into being.
So tell us about ICU psychosis. What is that, and how does one manage that?
So ICU psychosis is usually with patients when they're sick and they get admitted. They're not in their usual, place.
Mm-hmm.
So they start hallucinating. They start under stress. That they start behaving differently. How it can be prevented, like we usually tell people, to limit the noise, to limit the lights, to make sure that the person gets to sleep well. And all of that is very difficult because usually some places have ICUs with designated beds, but you have machines that are ringing, you have constant activity around, which is already disturbing the patient. Sleep, nutrition, all those basic elements are being disturbed. And that results in a person behaving differently, which usually, alarms the family a lot. It alarms everybody a lot. The doctors know this is ICU psychosis, and most of the time I've seen it dramatically changing as soon as you shift them into a personal room, where they're just them by their family. But explaining it in that moment is difficult. For the patient who's specifically the attendant, for him to see his own loved one in that situation is difficult. However, it is a reversible situation. And I was also reading somewhere when you have, these psychoses, or whenever an elderly is admitted and you have the first signs of such a thing, delirium, develop, then it is usually one of the things that later on predicts that the person will have dementia, or, elderly already being hospitalized come out with a lot of hazards of hospitalization. Most of them come back with, some problems that weren't already there. And I've seen that very closely with my grandmother. I've seen that with some of my patients as well, being a geriatrician. So yeah, preventing it is one of those common things that most of us doctors know. You limit the people going in, you limit the noise, you make sure the person sleeps, you make sure the person eats, you make sure, things are in semblance to his routine activities.
So ICU psychosis or other causes of delirium, of course, fairly common in the geriatric population. Now, how did this story with your grandmother, how did that affect you as a geriatric fellow? How does that affect you as a physician?
Every time I see someone in delirium, that's the first thing that comes to my mind. And I have to go through this in my mind every time that, okay, this will get better. And it also reminds me of the time, I was hearing a lot of things and how they were affecting me emotionally. So I also kind of start thinking this would be affecting the other person. So that is what happened. But, when you're in the shoes of a consultant or a doctor, at that point, you think of the solutions. So you are not somebody who's, emotionally involved. You're actually trying to fix the things, the situation. So you're putting things down as the pieces of a puzzle so that you come down to a conclusion, a diagnosis. So, and I think that that's applicable to every consultant out there.
Now, when families come to the hospital or their loved one, their elderly loved one is admitted, is there anything that you do as a physician to help prepare the family for the potential of delirium?
We always leave them with instructions of how they can, prevent problems at home. So there is a whole geriatric assessment that happens. It usually happens in the clinic. From a hospital standpoint, we do refer them to a geriatrician. We do discuss some solid points of any geriatric patient, and the referrals are made to the geriatric clinic where the whole assessment takes place. And, I'll take this platform to just say that everybody above the age of 65, go for a geriatric screen. Like, it's so helpful. And then maybe you could have it every year so they could also follow how your mental development is going, how eager you're deteriorating. If you need some help in certain areas of life, it doesn't have to be health, it could be just home-wise. You need help to come in once a week, you can't do things yourself. Maybe the geriatrician would be able to help you with his team. If you have problems with somebody in the house you can't talk about, you have them to listen to you and maybe come up with a solution which can work for both. And there are a lot of times we help people that way.
So when you said that over the age of 65, you should consider a geriatric screen, what exactly would that consist of?
So geriatric screen would consist of a lot of things. We usually start talking about the active daily life, the instrumental active daily life. Is the person able to cook, eat, bathe themselves, shower themselves, take care of their finances, or somebody else is taking care of them? Driving is a very important aspect. People at the age of 90, they want to drive. But again, it's very scary because if you are not, if you're developing even the initial signs of dementia, if you have slight Alzheimer's, you can get lost in your own surroundings. You can end up in accidents, and we've had patients like that. So those things are a part of the screening that happens. Then we do these 4 M's that I really like. That's what matters most. So that way you also know a bit about the patient in general, like what matters to them, what's important for them, what makes them happy, if they have their activities, hobbies, and what goals they have. And then that way you have a general picture of how the patient is doing. And if they're not sad or depressed or something's happening. And then you also look at their ability to remember, recall things. That way you screen them for dementia or any health hazards or any mental complications that they might be developing. I feel like that is really, really helpful because that way we could suggest things that could, improve your life outcome in the next coming months. We could screen you with your blood test with what can be prevented. We can look at your medications and deprescribe. One of my favorite things to do is cut down on the medications that are not needed. And I remember this used to happen in Pakistan a lot. It happens here too, that a patient is on a set of medications, and there are many because they're going to certain doctors, and some of them are not needed on the list. Some of them are the ones that could, they're the ones that slowed the they cause cognitive impairment. So what we do is we have conversations with the other consultants and we try to put them off. And that really, really helps. A lot of times I've had patients on follow-up who said that, okay, the memory hasn't deteriorated and the patient has been static or he has improved, and that is what that really, really matters.
We're talking to Natasha Khalid. She's a geriatrics fellow. Her Kevin MD article is titled Remembering My Grandmother in the ICU. Natasha, tell us some take-home messages that you want to leave with the Kevin MD audience.
Okay, for the audience of Kevin MD, I think this is an amazing portal to write. It's for the residents who are listening. Whenever you see something that affects you or gives you a different perspective, and write about it because it's so relatable. And like I always say, 10, 20 years from now, people would wonder how medicine was practiced back in the day, what we went through, and these stories would help you with understanding, because I feel like things are developing at such a high rate. People wouldn't know how interactions were based, and maybe some things would be similar, some things would be different. So, and it's so relatable every time I read somebody else's article. Every time I'm writing my own, sometimes I go back into my own article, oh, this happened, and I feel like these are the best narratives that are there in this collection. Add to it.
Natasha, thank you so much for sharing your story time and insight, and thanks again for coming back on the show.
Oh, thank you for always having me.